I'm Dr. Brian Koffman, a retired family doctor and the co-founder, chief medical officer, and the executive vice president of the nonprofit CLL Society. Dr. Shoham, can you introduce yourself?
Hi, Shmuel Shoham. I'm an infectious disease doctor at Johns Hopkins. I'm professor of clinical medicine at that institution, and I focus on infections in immunocompromised patients, particularly those that have cancer, including lymphoma, leukemia, and solid organ transplantation.
Well, let me ask you this before we get going to what we're going to talk about is that you must see a number of CLL patients. And one of the pushbacks CLL patients have run into is that they're not being recognized as being immunocompromised, even when they're treatment naive, even when they're in remission, when it's a cancer of the immune system. Do you have any comments or thoughts on that?
Sure. So CLL is a real area of concern with COVID. And the reason for that is that one of the best ways that the body has of preventing COVID is antibodies. And people with CLL often don't have the right amount of antibodies or the proper antibodies to combat a range of infections, viral infections being a big part of that, and COVID being a part of the viral infections.
Yeah, so this is something that we can talk about more, but you've found a therapy, or not refound a therapy might be a better way to say, where we're actually giving people those antibodies. Could you explain a little bit about what your research is and what you're doing, and maybe kind of bucking a trend here a little bit? If you could give us a little bit of a background on what you're doing to offer some hope to the immunocompromised.
Sure. So in terms of immunization, there's two ways of immunizing somebody, of giving somebody immunity. One is called active immunization, and that's the famous one. That's the vaccines. And you give a product, the body processes and then starts making antibodies against the product, and also can make other parts of the immune system active against it. For many people, that is something that is a challenge, either because they have an immunocompromising condition or are on certain medications. And so that's where the concept of passive immunotherapy comes in, passive immunization. And that is, you give antibodies that are already formed, and those antibodies could be formed by other people. Many of your colleagues and your patients have probably gotten intravenous immune globulin or injected immune globulin. So it's that concept of getting antibodies that are formed by other people. And you can also make the antibodies in the laboratory, and people may have heard of monoclonal antibodies for COVID, and that's what that is. Probably the most famous of the monoclonal antibodies now is Evusheld, which is used as a pre-exposure prophylaxis, even before somebody's been exposed to COVID, as prophylaxis. So we worked on a passive antibody product called convalescent plasma. So convalescent means that somebody has had an infection and they got over it. And plasma is the part of blood that has the antibodies in it. If you take a unit of blood and you break it down, then there's the red cells, there's platelets, but there's also the plasma, which is a orangish color material that has clotting factors and antibodies. So if you take the plasma component of somebody who's had COVID, and particularly somebody who's both had COVID and has immunization, you're going to find very high levels of antibodies against SARS-CoV, against the virus that causes COVID. And back in the 19th century, people were starting to use plasma, or serum is another term for a very similar material, as a treatment for infections. And that fell out of favor because it was more complicated than taking a pill. However, for certain infections that don't have good therapy, or that pills have not been made for, then that type of therapy can be useful again. And we started working on that early on in COVID because there was nothing. very quickly we found out that there's people that it does not work in, and there's people that it does work in, and then there's people in sort of in the middle range. And because a lot of the early studies were focused on people that it didn't work in, people were desperate. They wanted to give something to somebody who was sick enough to be in the hospital, and particularly somebody who was in the intensive care unit, very sick, and they gave them convalescent plasma and it didn't work. Then that created a lack of enthusiasm for this product. But we and others continued working on it, saying you got to give the right drug at the right dose at the right time. And over many months of work, we've honed in the right dose, the right time, and the right person to get it. And the right person to get it is ideally somebody who cannot make enough of their own antibodies to fight it, so that you give them somebody else's antibodies. Now, ideally, you give somebody a vaccine before they got the disease in the first place. They would make their antibodies, and there wouldn't be any need for any of this. Unfortunately, there's people like people with CLL who cannot make their own antibodies consistently. And for those people, when they get sick, giving them a slug of somebody else's preformed antibody may be exactly what they need.
So the convalescent plasma, and this is hybrid, I think, is the best convalescent plasma, where they've both been vaccinated and gotten the disease, had a breakthrough infection. It's important to know how much antibody is in there, what are called high titer antibodies. Could you talk a little bit about that? And for what population and when should this be used? And let me add a second question, and you can deal with this. And how does this work with things like Evusheld or bebtelovimab, which is a different antibody, a short-acting antibody for somebody who's got COVID? How do all of these things, and now there's Paxlovid, antiviral pills that you can take. How does all this work together? Help us, because this is what you're dealing with on a daily basis as an infectious disease specialist. Yeah.
Exactly. So, so the first part is you got to give enough antibody that is active against the virus for it to work, and you got to give it at a time when it can work. So, if you give it to somebody who is in the viral stage of infection, that is, that the virus is doing the damage, then that has the best chance of working. If you give it to somebody that the virus is already controlled by the immune system, but that the damage now is by an overreaction of the immune system. And that's what happens in a lot of non-CLL patients, is that by the time that they're in the hospital, particularly in the intensive care unit, the body's natural healing ability is doing a pretty good job of controlling the virus. In fact, it's doing such a good job that it's overdoing it. And that's what's causing the damage. So for somebody like that, giving them an antibody that's going to act as an antiviral to kill the virus, the body's already doing that. No need for that. However, for somebody with CLL whose body is not doing a good job controlling the virus, they have a high amount of virus, that's where an antiviral is going to shine. So what kind of antiviral is going to be? Is it going to be a pill? Sure, why not? If it works and there's no contraindication, there's no reason not to give it. For many patients are on medications that could have a interaction with it, like tacrolimus or sirolimus or everolimus. If somebody's on that,
or ibrutinib or venetoclax or acalabrutinib, which are drugs that are used to treat CLL. Yeah.
So those could be problematic with Paxlovid. But if you're not in that situation, or if you're in a situation where the pharmacist and the patient and the doctor can navigate all that, then Paxlovid would be better, because it's a pill. Who wouldn't want to take a pill for something as opposed to something injectable? However, if that's not on the table, then a drug that is an antibody could be exactly what's needed. So bebtelovimab is a monoclonal antibody. That's a laboratory formed antibody that is directed against the virus. And the current viruses that are most common in the United States are sensitive in the laboratory to bebtelovimab, and there's no reason to think that this laboratory sensitivity won't translate to working in the body. So if bebtelovimab is available, sure, give it, because it's something that's going to work. If bebtelovimab is not available, or if we're smash cut to sometime in the future where bebtelovimab might not work, then that's where another product would come in, and that's where convalescent plasma is going to shine, because again, it's antibodies. It's just like bebtelovimab in that way, in that it's antibodies, and if you get it from somebody who's had COVID and has been vaccinated and recovered from the COVID, then you expect them to have very high levels of antibody, and you expect that at least a bunch of those will be effective against the virus. Now, how do you know that for a fact? So you can test that in the laboratory as well and say, okay, do they have a high concentration of anti-SARS-CoV antibodies? And if they do, then you can expect that it will be effective at killing the virus. Now, will it make the person better? That depends on a lot of things. It depends on where they are in the arc of the disease. Again, if they're in the part where the virus is causing the damage, then I expect it to help. If they're at a part where the virus is under control and what you're dealing with is the damage of the virus or the damage of the immune system, then it probably won't help. Now, the thing is with CLL patients is that they don't, as I don't need to tell you, fit into neat little boxes. And that I'm sort of describing an artificial situation where you're in the viral stage, in the inflammatory stage, in the post-viral stage. Well, that's not how life works for a CLL patient. They can be in all three at the same time, so that even some patients that a non-CLL patient would be, you'd say, okay, too late for Paxlovid, or too late for a monoclonal, or too late for plasma. In a CLL patient, even when they're sicker, even in the ICU, they may still get benefit because they could be having this combined situation where the virus is still causing damage because their body has not controlled it well, where the immune system is causing damage because their immune system is not, it's not an all or nothing phenomena. They have some immune system. And also it could be that you can have a super infection, that there's a bacteria and a fungus that's acting all at the same time. So I hope I didn't complicate things too much, but CLL patients are not somebody that can fit into a neat little box.
No, and I appreciate that. We say, if you know one CLL patient, you know one CLL patient. We're all different. Help me understand. I understand the monoclonal antibodies, but we've a lot of those are X'd out now. So the drug like RegenCov that famously helped President Trump is not active against the present strains of Omicron that we're seeing right now. And a number of others have fallen by the wayside that we've seen that we're all excited about. And really the last ones standings are Evusheld, which is not to treat COVID, but to prevent COVID, pre-exposure, and bebtelovimab. But this, the convalescent plasma by its nature is polyclonal. Okay, so could you explain a little bit about that, whether it works against the present variants of concern that we're seeing? And do you think it's going to have a longer shelf life in terms of it's still going to work in 3 months from now, when who knows whether any other antibody will still be working in 90 days with how quickly this virus seems to mutate?
Sure. So that's one of the reasons why we worked hard on developing convalescent plasma as a therapy, is because it is more durable as a polyclonal, as something that affects the virus at multiple targets. As the virus becomes mutated and resistant to one target, because the body is much smarter than anything we can make up in the laboratory, then there's multiple targets of the virus that it goes after. So we expect it to remain effective. Now, that having been said, plasma that was collected, say, in April of 2020 is probably not going to be as good as plasma that is collected in April 2022, and probably even then not as good as plasma that's collected in July 2022 in San Francisco to be given to somebody in the Bay Area, because there are so many little variations, and we found that the geography and the timing of when the plasma is collected is important. Now, those issues can be overcome by the enormous levels of high antibodies that people that have the hybrid, that have been vaccinated and have had COVID, particularly a more recent vintage of COVID, then you can overcome that. But if I had to choose, if I had, like, if Mother Teresa was still alive and she came down with COVID, and I could choose any product in the world, I would say somebody who's been vaccinated in Calcutta and had COVID in Calcutta and recovered in July.
All right. So let me ask you what the present, we're talking now at the end of July in 2022. What's the present status of convalescent plasma? How accessible is it? Is it part of the management of the immunocompromised patients across the country? It sounds like it probably is at your institution, Johns Hopkins, but is it recognized at many centers across the country? Is it something that patients who are vulnerable still have a significant mortality rate with CLL morbidity rate? Is it something we have access to?
So yes and no. So the no part is that many people are not aware that it's available and effective in this population that you're talking about. In that it's gotten a lot of press, some of it good, some of it bad, as a treatment for general population of people with COVID. So for example, for a general population of people with COVID who are hospitalized, the NIH and the Infectious Disease Society of America do not recommend convalescent plasma for those people. However, those guidelines aren't specific enough to really home in on CLL patients. And the data is that in such patients, even if hospitalized, then it is effective. It's not as strong a level of data, phase 3 randomized controlled trial, because there's just not enough people like that, but there's enough good data from other types of studies to say in this patient population, it can be effective. So you go into a hospital at a major university teaching hospital where people are very used to treating CLL patients, then and you say, is convalescent plasma a possibility for me? The chances are they'll say, yes, it's a possibility for me. On the other hand, you go into a place that isn't used to taking care of people with CLL as often, then they may say, no, it's not. It wasn't proven to work. We're not giving it because they may not be as sophisticated to the subpopulations. So I think that like everything else in your field, I know that you and your patients have become used to being advocates for yourself. You have to say, yes, it can be effective. Please look at the data, review it. I'm not talking about taking snake oil here. This is something that has a body of evidence behind it. And then when they say, but our hospital doesn't have it, you can say, please have your blood bank work on getting it, because there are suppliers in the U.S. I don't have stock in this, but Blood Centers of America is one example. A very well respected blood collector. They have supply of it. And your blood bank can find a match for your blood type to get it to you. It often takes a little bit more work. It's not as easy as when you come in and they give you an IV antibiotic off the shelf, because this is a little bit more exotic.
Very interesting, very exciting, in certainly a moving target right now. Any final thoughts, any advice to the immunocompromised patients who've maybe been able to dodge COVID so far, or thinking about how this convalescent plasma would fit in?
Yeah, so I think people have to really be advocates for themselves, as I said, and remember that convalescent plasma is a blood product. It's not a pharmaceutical product. It doesn't have a Fortune 500 company behind it with educating clinicians, going out to lobbying members of House legislators and Congress to make it available. It's really a grassroots thing, with all the positives of grassroots, but also the pharmaceutical industry is very good at getting a drug from molecule to market and making sure it's in people's mind. And this has not had it. It's had a bunch of academics and grassroots organizers advocating for it. So it takes a little bit more work, or even sometimes a lot more work on the side of the patient, to be aware that this is a possibility and to call for it.
Doctor, thank you so much. This is so helpful. This is very interesting, and know that you have an ally in the CLL Society, and we're going to work together. We have some ideas that we talked about in terms of trying to get the word out, try to get the word out to our community, and maybe try to give them some information that they can take to their local community hematologist about convalescent plasma should the need arise. Thank you so much for the work you and your team are doing. Thank you.
Thanks. And I would say that all the work that we're doing is for you. It is a passionate desire to help immune compromised people who are there's a lot of them, but they are sometimes forgotten by the medical establishment because they're still a minority with very special needs. So we do it for you.
Dr. Shoham, thank you so much.